Thank you very much. And we will keep the question to the end, and we will move to another topic on inflammatory breast carcinoma, and nobody can cover this topic better than Professor Ricardo. Professor Ricardo is a director of Cancer Research Cancer Treatment Center at Atlanta, USA, and he already titled his presentation as Inflammatory Breast Cancer Management, New Insight of an Old Disease. So please, Professor Ricardo.
Thank you for this kind introduction. Good morning, everyone. It's a real privilege for me to be here. This is my seventh BCRGG, so I think I've been one of the pioneers in coming here with Dr. Hesham. He kindly continued to invite me. Pardon me? Flash. Doesn't work? Oh, didn't work? Okay. So can we do the next speaker and I coming back? You don't mind to do this?
Yeah.
Because my flash didn't work. Okay.
Okay.
I'll be back.
Let me call now Professor Fedro Peccatori from Italy. Professor Peccatori, he's the director of the Fertility Unit, Division of Gynae Oncology, European Institute of Oncology in Italy. And Professor Peccatori will talk to us the breast cancer during pregnancy. Please, Professor.
Yeah, I was really looking forward to hear about inflammatory breast cancer, but you'll have to listen to the breast cancer during pregnancy presentation, which is my presentation. It's kind of my passion. I would like to thank the organizing committee for inviting me here, and also Botticelli for having drawn such a nice Venere. And what I'm going to tell you in the next 20 minutes is something about epidemiology, biology, diagnostic procedures, and some surgical and systemic treatment of breast cancer when it is diagnosed during pregnancy. And indeed, breast cancer is the most frequent oncological diagnosis during pregnancy. Around 1 out of 3,000 pregnancies are complicated by breast cancer, which represents about 5 or 10% of breast cancer occurring in young women. And unfortunately, the numbers are increasing, and that's mainly due to the fact that age at pregnancy is increasing. These are figures from United States, but it's the same also in Europe and in Italy. And at least from some cancer registries, there is also an increasing incidence of breast cancer occurring in young women. So this ends up to numbers which are not trivial if we consider that every year worldwide there are more than 130 million deliveries. This means that a little bit less than 50,000 new cases of gestational breast cancer are diagnosed every year worldwide, and in Italy it's around 200 of new cases per year. What are the biologic characteristics of gestational breast cancer? The question that we asked, are they similar to the biologic characteristic of breast cancer in young women, or does pregnancy change some things in terms of immunohistochemistry, gene expression profile, or even the mutational profile? We did a study a few years ago. It's case control studies. We looked at our database. We found pregnant breast cancer patients and matching controls, and the matching variables were quite stringent. And this is what we observed. You can see that the pregnant cases, of course, were young. The median age was 36 years. More than 60% of patients had node-positive tumors, and around 60% of patients had tumors larger than 2 centimeters, which reflects somehow the fact that these tumors are often diagnosed late. If we look at the biological characteristics of those cases, again, you can see that they were usually quite aggressive tumors. Estrogen receptors were absent in around 40% of patients, grade 3 in 60% of patients. High Ki67 was present in more than 70% of patients, and HER2 new positivity was around 17% of cases. And when we compared the pregnant cases with our controls, we couldn't find any difference. So probably we didn't really have a real effect of the pregnancy on the biological characteristic of the pregnant tumors, as you can also see from the molecular subtypes as defined by immunohistochemistry. We did another study in the same subset of patients. We excluded the neoadjuvant cases, we excluded poor RNA quality, and then we looked for genomic features of breast cancer diagnosed during pregnancy, and we compared it to breast cancer diagnosed outside pregnancy. And again, when we look at the mutational profile of a number of gene sets, we couldn't really find any difference, particularly for PK3CA gene mutation. And the same was for gene expression profile, or better, we saw a difference between some gene expression profile modules genes for beta-catenin, SRC, IGFR1, and also PD-1 and PD-L1, but those differences occurred also in normal pregnancies. We couldn't do, of course, biopsy of the breast during normal pregnancies, but we had the information from the mouse model. So we are still looking for an answer. We don't have a definitive answer. Apparently, pregnancy does not change the biological characteristic of breast tumors. We are now doing whole genome sequencing of the same data set. And of course, we are also looking and investigating hosts. We already published some data about TILs, but we are still doing other studies about that. What about prognosis? In our data set, the prognosis of the pregnant cases was a little bit worse compared to the non-pregnant control, but in other data sets, this was not reproduced, and maybe it's just a matter of the number of cases, selection of cases, and maybe also treatment. Our cases were quite old in terms of treatment. What about the diagnosis? I already alluded to the fact that pregnant breast cancer patients are usually diagnosed late, and this is due to a number of prejudices. The first one is that you shouldn't do any investigation during pregnancy. Mammograms, on the other hand, are extremely let's say, informative, particularly for microcalcification, but the gold standard remains the breast ultrasound that, by the way, does not have, of course, any effect on the fetus. And all the persistent breast nodules should be indeed evaluated. For surgery, there is no difference in the surgical approach of breast cancer diagnosed during pregnancy compared to the breast cancer diagnosed outside pregnancy. There is no reason to do mastectomy for a PT1 small breast cancer nodule. You can do quadrantectomy. Of course, you should be careful in the anesthesiological evaluation. You are treating a patient who is pregnant, so particularly for the liquid balance, you should be very keen in maintaining it properly. The fetal monitoring is an issue, particularly after the 30 weeks of pregnancy. And we decided that after the 25th week of pregnancy, patient should be operated where a proper obstetrical monitoring is available. There are no reason not to do a lymph node sentinel lymph node mapping. We know that there is no issue in terms of safety. Also, when you use technetium, the sentinel node mapping is safe. We demonstrated that in the models in non-pregnant patients. We published the data in pregnant patients. This is, again, an old series where we are enlarging this series on 12 patients, small tumors. And in this series, 10 out of 12 patients had negative sentinel node, and so they were spared a useless axillary dissection. Another issue is breast reconstruction. It was thought that immediate breast reconstruction was a contraindication in pregnant patients because of the risk of prolonged surgical treatment. We actually have used it, and we have recently published our experience on 12 patients. And you can see the gestational age was 16 weeks, the mean gestational age. 10 out of 12 patients had an axillary dissection because the tumors was quite large, and 2 out of 12 had a post-mastectomy radiation therapy after delivery. As a matter of fact, in expert hands, immediate reconstruction with expander is not a long operation. It takes a little bit more than 2 hours. We didn't observe any maternal fetal complication. 75% of patients could complete expander inflation during the pregnancy, and we didn't observe any specific complication or issues, local or systemic, for those patients. Chemotherapy, again, this is a changing paradigm. It was considered a no-no ever for pregnant patients, but actually, and I'll show it in a minute, it's considered safe. Of course, you have to take into consideration gestational age, the drugs administered, the effects on pregnancy and fetus, and of course, the effects on newborns and children. Gestational age is very important. Of course, the embryos has a different susceptibility to the potentially toxic effect of chemotherapy. The let's say, most sensitive period in the first trimester was where the malformation rate exceeded 20%. So giving chemotherapy in the first trimester is still considered a contraindication. After the 16th week of pregnancy, there is actually no more, let's say, new organ formation, but just organ growth. So the malformation rate is very similar to the general population. What are the drugs that can be administered? Taxanes and anthracyclines are the safe drugs. There is a little bit less experience with taxanes compared to the anthracyclines, but both the drugs have not been correlated to an increased rate of fetal malformation or acute toxicity when administered during pregnancy. And that's probably due to the fact that both drugs are substrate of PGP, BCRP, and MRP2, which are, let's say, the proteins, which are the pumps, which are responsible for drug resistance, but they are also highly expressed in the placenta, and so they just push the drug towards the maternal site. And this is confirmed by the fact that the percentage of drug that can be found in the fetal tissue, these were of course animal experiments, is very low compared to the drug levels found in the maternal compartment, and this has also been confirmed in humans with the pharmacokinetic studies. As I said, you have also to take into consideration the effects on pregnancy and fetus. This is a paper published by Sibylle Leubel, which will be with us, I think, in the afternoon. And you can see that there is an increased rate of any obstetrical complication in patients who received chemotherapy during pregnancy. It's around 17% compared to 9%. Most of the complications were mild. Premature labor, premature rupture of the membrane, intrauterine growth restriction were the one most frequently described, even if their incidence were not statistically different from the patients who did not receive chemotherapy but had anyhow a breast cancer diagnosis during pregnancy. For the newborns, the only significant effect that was demonstrated was a median weight at birth that was a little bit lower compared to the same gestational age. But the important point, of course, is that the long-term cognitive cardiac outcome after prenatal exposure to chemotherapy was not demonstrated to be worse. As a matter of fact, those children whose mother received chemotherapy during pregnancy had the same general health, hearing and growth as in the general population. They had, most of the children in Asia, adequate neurological development and cardiac function, and even if prematurity was frequently encountered and was associated with cognitive development impairment, as in the normal situation of prematurity, so premature babies who are born for any reason before term might have reduced IQ, but that's a little bit a controversial issue because IQ depends on many issues and not only on gestational age. Nonetheless, we could confirm that the pediatric outcome after maternal cancer chemotherapy was not different from controls. This is a very recently published paper, and it was a case control studies, differently from the other one. And again, we could confirm that after gestational chemotherapy, indeed, the kids are all right. So the idea not to give chemotherapy during pregnancy, if it is delivered after the first trimester, is a wrong idea. You can safely deliver chemotherapy with anthracyclines and taxanes after the first trimester. In conclusion, breast cancer during pregnancy is probably increasing in incidence. It has the same histological and molecular characteristics of young women's tumor. There is indeed a need for proper diagnosis and education of the obstetricians. Surgery can be standard, including sentinel node biopsy and immediate reconstruction, and chemotherapy when needed after the 14th week of pregnancy is safe and does not hold let's say, late disturbances for the newborn. All of I presented could not have been done without many other people, and I must say the most important is Hatem Azim. I see here his father. He has been really the let's say, promoter of all these studies with enthusiasm and knowledge. But of course, also all the other people at the European Institute of Oncology and in Belgium were important in defining these studies. And I thank you for your attention.
So, thank you very much. It's very nice and very updated presentation. And we are honored that Professor or Dr. Hamdi Abdel Azim Jr., Hatem Abdel Azim, one of our great son who proved himself in this field, and we are all proud of his effort in Belgium.